A very good morning to one and all present here. So, as a part of neurodevelopmental workshop of the South Neocon 2021, I'll be speaking about organization of follow-up services, including risk stratification. So, myself, Dr. Usha Devi, who is an associate professor in Department of Neonatology, Chettinad Hospital. So, this is just an overview of my talk. So, why at all follow-up services are needed? What is the need and extent of problems that is necessitating follow-up of this neonates? And who are the candidates for this high-risk follow-up? How do we go about risk stratification of the neonates? And what are the prerequisites for setting up of follow-up service? And when and where do we do this follow-up? And how do we go about follow-up schedule? And in the follow-up, how do we assess nutrition, growth, immunization, hearing, eye problems of the baby, neurological and developmental assessment, and other issues? And what is the importance of early intervention, and how do we administer early intervention to the neonates and infants? And finally, we'll be ending up with take-home messages. So why at all we need neonatal follow-up services? Because there is increased survival of more and more preterm babies, even 23-weeker, 24-weekers are surviving, and the sick neonates who are surviving with the advanced neonatal care are increasing. So there are higher chances of handicap as well. And early identification of problem is possible only with the neonatal follow-up, and this will only also lead to early intervention and better outcomes in these babies. If we take very low birth weight babies, around 15% of this very low birth weight babies go on to have some neurological problem, and 4% develop cerebral palsy, 5% have lower IQ, and 19 to 21% need special education. So when we come more and more extreme preterms are surviving, when we discuss in particular about extreme preterms, so these are some of the data from other regions of the world. Epicure 1, which was done in 1995 in UK and Ireland, where babies born between 22 and 26 weeks of gestation were included. If we, when they followed up till 3 years and 6 years, they found out that at 3 years of age, only 39% of them were surviving, and survival without disability was only present in 23%. And a significant amount of babies had cognitive impairment at 6 years of age, and around half of the babies who survived required special education by 11 years of age. And in 2006, they thought they will see the trend in their neonatal survival and developmental outcomes. So they included a cohort of babies who were born in 2006 between 22 and 26 weeks of gestation. Even in these babies, so if we see at 3 years, there were half of them survived, but survival without disability was present in 34%. And moderate and severe impairment in survivors were present in 20% at 26 weeks gestation age. So this EpiPage study was conducted in France, which also showed that around 12% of babies born between 32 to 34 weeks of gestation also had moderate and severe neurodevelopmental disabilities. So, so this is a meta-analysis where they have compared survival of extremely premature infants across various countries, and they have found that in the 27 weeks of gestation, the severe impairment was around 2%, whereas it was nearly 20 to 25% at 24 weeks of gestation. So these are all showing that yes, more extreme preterms, as more extreme preterms and more very preterm babies less than 32 weeks of gestation are surviving, there are more chance for impairment and need for special education, cognitive problems, all those things, all those problems arriving in follow-up. So this again reinforces the importance of follow-up in these babies. This was a systematic review which was done in developing nations where they found out that neurodevelopmental impairment or cerebral palsy of any severity was present in 17% of the babies less than 1 kg, and 29% of the LGANs. LGANs means babies who were born below 28 weeks of gestation. And necrotizing enterocolitis, periventricular leukomalacia, those incidence and prevalence was similar to the developed nation. However, other morbidities like bronchopulmonary dysplasia, retinopathy of prematurity, all these morbidities were more in the developing countries when compared to the developed nations. And in ELBW babies, that is babies less than 1 kg, bronchopulmonary dysplasia was present in around 40%, and EUGR, that is growth restriction after birth due to inadequate nutrition, was present in 88% of the babies, and any stage ROP was present in 50%, and severe ROP was present in 25%. So all these things, and again say that the follow-up of high-risk babies or NICU graduate is very, very important to pick up all these abnormalities which can happen even till 8 years or 12 years of age, and adequate early intervention should be instituted to these babies. So goals of our neonatal follow-up services are to detect any deviation from the normal child development and start a early intervention, and also to give family education and support, to train the medical professionals who are involved in the follow-up of these babies, and also it is also done as a part of research purpose. So who needs high-risk follow-up? Okay, ideally rigorous follow-up of all the newborns who are born, whether they are term or preterm, whether they have morbidity or no morbidity, would be ideal, but it is not always feasible with the available resources. So we have to prioritize or mandate follow-up of the at-risk newborns, because these newborns are at higher risk than the other babies who are other well babies. They are at higher risk of developing adverse outcomes during follow-up. So we need to have a rigorous follow-up of at-risk newborns, and this follow-up is done based on a risk stratification. So based on the risk factors which the baby has, we can either put the baby under high risk, moderate risk, or low risk. So this is given in the NNF guidelines 2010, where babies born less than 28 weeks or less than 1 kg, or having morbidities like chronic lung disease, IVH, periventricular leukomalacia, severe asphyxia, HIE, having seizures, and some surgical conditions like tracheoesophageal fistula, diaphragmatic hernia, small for dead babies, large for dead babies, babies who require mechanical ventilation, and things like nitric oxide, ECMO support, meningitis, and shock requiring inotropic support, bilirubin encephalopathy, inborn error of metabolism. These are few conditions which directly puts the baby in the high risk category. These babies need a rigorous or follow. And in the moderate risk category, babies with birth weight between 1 kg and 1.5 kg, gestation less than 33 weeks, neonatal moderate HIE and hypoglycemia but without any seizures, neonatal sepsis but without meningitis, bilirubin requiring exchange transfusion but without any bind. All these babies fall under moderate risk. Mild risk babies are those between 1.5 to 2.5 kg, transient hypoglycemia, neonatal jaundice, IVH grade 1. And this risk stratification need not be uniform throughout the units. You can stratify the babies as high risk babies based upon your unit protocol. This is from AIMS protocol, where they have taken babies less than 1.8 kg, less than 35 weeks as high risk. So we can take maybe less than 1.5 kg or less than 2 kg also as high risk babies. Based upon the resources available in each unit, we can put the baby in high risk category, and we can make the baby to follow a rigorous follow-up schedule in our developmental unit. And so all those features if the baby has, the baby will be directly falling under high risk category. So what are the prerequisites to follow up this at-risk newborns? What are the prerequisites our developmental unit should have? First of all, even before discharging this high-risk baby, suppose we are discharging a 1 kg baby or a 26-weeker after some 6 weeks or 8 weeks stay in the NICU, and if you are asking them to come for a follow-up, high-risk follow-up, discharge planning should be done well in advance. And all the counseling of the parents should be done even before discharge of the baby. So discharge planning as usual, the baby has to satisfy a discharge criteria. So the baby has to cross the birth weight and should be having consistent weight gain for at least 3 days, and all the medication should be stopped except for supplements. Mother should be confident in handling the baby, and baby should not be having any ongoing illness. So all those illness should have been adequately treated, and the baby should be properly immunized. If there is any ROP screening, first screening, anything pending, that has to be finished, and hearing screening has to be done before planning discharge of the baby. All these things you need to plan well ahead even before planning discharge, and asking the giving a schedule to the parents to come for a high risk follow. This has to be done even before discharge, and counseling of the parents regarding, so what are the problems we anticipate in this baby, and so how high risk follow-up is very important for this baby, and where do they have to come for high risk follow-up, when do they have to come, all these things we have to counsel the parents. Apart from that, normal counseling, like when is their follow-up visit, any danger signs which they should recognize and should be able to bring back to the hospital, and where in case of emergency where they need to come directly to NICU or newborn unit, or in case of follow where they need to come, in case of developmental unit which specific place they have to come. All these things have to be adequately counseled even before discharging the baby. And for high risk follow-up, a single person, a pediatrician or neonatologist is not enough. It involves a multidisciplinary approach, and a team of personnel are needed to give a proper protocol based high risk follow-up to these babies. So pre-discharge surveillance we would have done for this baby. So any medical examination for ongoing illness, whether baby is able to maintain temperature by himself or herself without the requirement of warmer, and physical examination of the baby, whether baby has any hernia. If the baby has hernia, then we might need to plan surgery for that. And if the baby has some developmental dysplasia of hip, then we might get ortho opinion, some positioning need to be done, or any cast or splint has to be put for the baby. That has to be done before discharge. That has to be planned, and follow-up has to be planned. All these things will be done even before discharge as a part of surveillance. And we need to do a neurological examination even before. Regularly, we will be doing that in NICU, I suppose. And even before discharge, a thorough neurological examination is ideal. Either if the baby has reached the term gestation, we can do this Hammersmith neonatal neurological examination, or the baby is still preterm. Okay, good enough if we do Hamilton angles. So what is the posture of the baby? What are the Hamilton angles of the baby? All these things we can document in the follow-up card of the baby, and we can document in the discharge summary, so that it will be easy for the person who is following up with the baby in the high-risk clinic to know how the tone has evolved and how the baby was during discharge. Because we know that abnormal neurological examination and discharge implies that baby might have a poorer prognosis, and baby has high chance to land up in developmental delay on follow-up as the baby grows. And neuroimaging, we know that most of our units do a ultrasound at regular intervals. If the baby is going to be less than 32 weeks or less than 1.5 kg baby, we would have done a first ultrasound within 72 hours of life, and by 1 week of life we will be doing a second ultrasound, and by 28 days of life we'll be doing a third ultrasound. When the baby reaches the ETT or term gestation, we will be doing another ultrasound or MRI ideally. And then coming to ROP screening. So based upon the unit protocol, whether the baby is going to be less than 32 weeker or less than 1.5 kg baby, we would have done a ROP screening. And the lesser the gestation, we will be doing ROP screening. earlier, 2 to 3 weeks, to pick up a aggressive posterior ROP. And hearing screening should have been completed even before discharge of the baby. And screening for congenital hypothyroidism, routinely many units are doing by 72 hours of life. And screening for metabolic disorders like congenital adrenal hyperplasia, doing a serum 17 OHP, or many units follow this panel 1, panel 2, and send a screening tandem mass spectroscopy, TMS, to pick up any metabolic IEMs, to screen for any inborn error of metabolism. So all these things has to be completed, and the checklist has to be ticked before the baby is going to get discharged. The previous speaker has discussed in detail about MS with neonatal neurological examination. So the posture, tone patterns, reflexes, movements, any abnormal signs, behavior of the baby, all those things you'll be documenting before discharge of the baby in your summary itself, so that it will be easy during the follow-up. So as I already told, a single person is not enough. We need a set of people like a pediatrician, neonatologist, along with a child psychologist, pediatric neurologist, ophthalmologist, otorhinolaryngologist, dietitian, and each one has a specific role. So a pediatrician will identify ongoing illness and will give treatment for that. He will be assessing the growth and development of the baby. A child psychologist is needed to put a formal developmental assessment like DASI or Bailey developmental assessment. A pediatric neurologist to address any seizures which the baby might be having, any tone abnormalities, the medication needed for the spasticity, all those things pediatric neurologist will be doing. An ophthalmologist to follow ROP screening, to pick up any squint or nystagmus, to give a early intervention and corrective surgery or corrective intervention for the same. Otorhinolaryngologist, the baby might be having congenital hearing loss, which has to be picked up very early, because baby might develop communication problem if the baby is not picked up early. And interventions like cochlear implant or hearing aid has to be instituted at the appropriate time. Dietitian might be able to address a failure to thrive and help in the nutrition part. And medical social worker, if the high risk neonate has not turned up for follow, then medical social worker might be able to coordinate and ask them to come for follow. A physiotherapist who can institute exercises for any tone abnormalities and and then give exercises and counsel the parents, teach the parents regarding exercises which has to be given in the home also. Speech and occupational therapist, in order to provide rehabilitation in a baby who is having any speech problem or any disability. So all these people have a definite roles, and it is not a single person. A group of personnel is needed to do a high risk follow-up in this at-risk neonate, where the venue of the child development unit should be communicated ahead of discharge and specific days. In some places, it will be working only in 3 days, 3 specific days of a week, child development unit, Monday, Wednesday, Friday. So it is in the first floor in room number 20. And you have to come Monday, Wednesday, Friday, and timing is between 8 a.m. and 4 p.m. So all these details have to be communicated to the parents before discharge of the baby. So follow-up date and time. When is the first follow-up? Suppose I am discharging the baby on 27th. Then baby has to come to review on 30th in the OPD, in the neonatal OPD. And after that, every month baby has to go to child development unit, and on specific days which should be mentioned in the card, follow-up card. Regarding the follow-up card, I will be speaking in the subsequent slides. And this registration in the development unit, it need not be done after discharge of the baby. It can be done even before discharge, when the baby is still in your postnatal ward or KMC ward, or baby is still in NICU. And we need to have a record in the NICU regarding who are the high risk neonates getting discharged from the NICU and when is due for follow-up. We need to maintain a note or a record regarding the details of the babies at risk units who are getting discharged, along with the contact numbers, so that they can be followed up if they are not turning up for follow-up. So child development unit, we need to tell the specific venue, working days and time. So we need to give them a specific child development. Can you pass? Spooty, can you pass? So this is a developmental follow-up card which we give to high-risk neonates, consisting of baby details, and this record will go with the baby when the baby is getting discharged, and details for follow-up, details regarding immunization, what are the developmental milestones, and details. Concise details about the babies, so that the baby can be stratified into high risk or moderate or low risk. These details also will be written in this follow-up card. And so we'll be shortly writing about the demographic profile and family history, because we know that the socio-economic status also will add up to the risk category of the baby. Maternal history and baby details, what is the birth weight, what was the head circumference at birth, and what was the gestational age at birth, and risk categories for neurodevelopmental outcome, shortly any intrauterine insults in the baby, need for resuscitation, details of mechanical ventilation, blood sugar level, hypoglycemia, how many days baby was on hypoglycemia, whether baby had seizures, HIE, whether baby was on ventilation, nitric oxide, ECMO. All these details will be shortly written, so that on follow-up, the neonatologist, pediatrician, or the psychologist who is following the baby, all the team members can know what sort of risk the baby had during the perinatal period and the postnatal period, which has led to the developmental delay, or whether we can anticipate any developmental delay in that particular baby. So these details will help the team members in anticipating, putting the baby in at-risk category, as well as in anticipating any developmental delays. So
it's 12
o'clock. So this is a developmental card which will be given to the parents when the baby is getting discharged, and they will be having a schedule in the developmental card which they will be following up. And so schedule for follow-up is roughly like preterm babies, either 1.8 kg or less than 2 kg according to the resources available in your unit, and preterm babies less than 36 weeks of gestation, we will give them a shorter interval to come back for follow-up, maybe 2 to 3 days, because they need to adapt. We need to check them. Since they are preterm baby, they might have problem in adaptation at home. They might not feed well, they might have hypothermia, they might have excessive weight loss, all those things. So they will have jaundice, more chance of jaundice. So all these babies need to come in 2 to 3 days time, so that we can check how the baby has adapted. And then every 2 weeks till the baby reaches a birth weight of 2.5 or 3 kg, and thereafter we can just combine our follow-up visit with the immunization visit, like 1.5 months, 2.5 months, and 3.5 months, so that it will be easy, and it will not be missed also. And after this 3 months, and after a baby reaches a good weight also, baby need to be followed at 3 monthly interval for developmental and neurological assessment at 3 months, 6 months, 9 months, 12 months. And ideally this follow-up, even after 1.5 years, baby has to be followed up every 6 months, because baby was at risk category in the neonatal period. So baby has to be ideally followed up till 8 years, and more ideal one will be to follow up the baby till adolescence also. All other conditions like morbidities, all other morbidities, we can give an interval of 1 to 2 weeks to come back for discharge. Again, it depends on the morbidity and sickness of the baby for which he was admitted. We can initial visit, we can combine with the immunization visit. Later 3, 6, 9, 12, we need to call them for developmental assessment. So this is a early stimulation program. This sheet is also incorporated in the developmental booklet which the parents are having. So growth assessment will be done for the regularly monthly till 3 months, and then every 3 monthly head circumference length, everything will be documented. If the baby is of low risk or moderate risk, you can put some screening test like Trivandrum screening test or CDC grading for motor milestones, whether baby has reached a good head control, or baby is sitting which is appropriate for the age, and Hamilton angles can be documented in each month. and thereafter every 3 months. So since the baby, if the baby is neurologically, appears to be neurologically normal at discharge, do not have any red flag signs, then we can put some screening tests like Denver developmental screening test too, or Trivandrum development screening test. All these things we can put, and we can assess the domains: gross motor, fine motor, language, personal, social domains. All these domains we can assess whether the baby has reached the domain which is appropriate for that postnatal age. So remember that when assessing this development and neurological status of the baby, always we need to go with the corrected age till 2 years. 2 to 3 years there is some discrepancy, but at least till 2 years we need to go for 2 years corrected age. That is taking into account the prematurity factor also. And other any associated problems like baby has spin tone nystagmus, all these things have to be documented, like DDH or failure to thrive. All these things have to be documented. And what is the impression of the doctor or psychologist whoever is seeing the baby in follow-up and their signature. These things have to be put. And we have a schedule attached, as I already told in the booklet, where neurodevelopmental follow-up will be done at 2 monthly or 3 monthly interval, and 2 years, 3 years, 5 to 6 years as well. And ophthalmology ROP follow for all the babies less than 32 weeks gestation, less than 1.5 kg baby, and squint evaluation at 8 to 9 months of age, refractive error, visual acuity check at 1.5 years and 2 years of age. Hearing checkup mandatory for every baby. Screening has to be completed within 1 month, even if there is any problem with the baby has failed hearing screening. A proper comprehensive audiology testing by the audiologist should be finished by 3 months, so that we can give a early intervention and baby develop proper communication skills. And behavioral hearing screening by 8 months of age. Speech and language assessment at 1 year corrected age for premature baby, 2 years, 3 years, we need to do those things. Psychology assessment, either TASI or Bailey, whichever is followed in our unit. So there is, whenever a particular, like 4 months developmental assessment is done, hearing test completed, nutritional assessment is done, we can put tick here. We can write risk factors of the baby, EDD of the baby, corrected age of the baby, and once the baby comes in the particular, like 4 months postnatal age, if the baby comes, we can just circle it or put tick for whatever testing that has been completed. We can just tick it. So coming to the follow-up, so there are different things we need to look into during follow-up. Coming to nutrition, we need to ask the mother what sort of feeding, whether she is confident in feeding, whether she is giving DBF, for how much duration, what is the frequency of giving DBF, whether she is giving pala-day feeds, how much pala-day, roughly how much amount whether she is giving, and adequacy by the weight gain of the baby, and after having feeds, whether the baby is sleeping for 4 hours, baby is voiding for 8 to 10 times, and if the baby is more than 6 months, whether she has started complementary feeding. We can give advice regarding complementary feeding as well, to start semi-solid diet, like infant and young child feeding guidelines, saying that 2 to 3 times babies between 6 months to 8 months age should give complementary feeding for 1 to 2 times, and as a baby becomes 9 to 12 months, 2 to 3 times feeding can be given, feeding with semi-solid diet, and slowly from semi-solid they will be switching over to solid, and after 1 year additional snacks also can be given apart from this 2 to 3 times feeding, and DBF will be continued till at least 1 year of age. And regarding supplements, so whenever a NICU graduate get discharged, we all know, no, baby will be on multiple medications. Most of it will be stopping. Even caffeine will be stopping at least 1 week before discharge, and we will be seeing whether baby is stable without any apnea or desaturation for 5 to 7 days. And fortification. Many of the babies born less than 32 weeks, they will be on this multi-component fortifier, which will be added some one sachet in 25 ml, like that we will be adding. No? This fortification can be stopped as the baby reaches the EDD or term gestation. And many units stop this fortification once the baby reaches 2.5 kg. It varies with units. And calcium and phosphorus supplementation, we can see the investigations, calcium, phosphorus, alkaline phosphatase of the baby, whether it is normalized and whether the baby is taking adequate feeding and calcium and phosphorus supplementation can be stopped by term, that is CDD. Iron and vitamin D supplementation, however, will be continued till 1 year of age. And vitamin D, as per recommendation, 400 units by as recommended by AAP, and iron syrup also will be continued till 1 year of age. So we have this preterm investigations. I don't know if the baby's calcium, phosphorus, ALP has reached normalized, then we can consider stopping calcium and phosphorus in follow-up syrup. So this is a preterm checklist which we maintain in our unit, where this ultrasound cranium, screening cranium, day 1, day 7, 28 days scan, this will be documented. So due date you can write here and keep. And then thyroid function test, preterm baby, so we have repeated twice. And when was caffeine stopped, when was 45 started, and when was it stopped, and hemoglobin, alkaline phosphatase, calcium phosphorus, starting from week 1, what is the trend, what is the calcium phosphorus, ALP at discharge. All these things have to be documented. And regarding ROP, what was the first screening report and what was the follow-up ROP screening report, which zone, which stage it is in. So all these things we will be documenting. What this will be there in the NICU chart. What we will be doing is, we will be taking a Xerox copy of this preterm checklist and attached to the discharge summary, so that the on follow-up, all these things, all these things can be tailor-made, that stopping calcium phosphorus or repeating calcium, whether, so the phosphorus is 3.9, so we need to, even if it is term, we need to repeat this calcium phosphorus to see whether phosphorus is normalized to 5.5 or not. So all these things can be done when this checklist goes along with the discharge summary. Growth charts, appropriate growth charts. In NICU, different units follow different growth charts. We follow Fenton growth charts, and many other standard growth charts are followed, like intergrowth charts are also followed in some units. And weight, length, etc. Means all these things will be documented in the NICU period. Any growth faltering should be picked up, and this should be done in. This is a continuum, not only during the NICU period. This should be continued even after discharge. Say this is a growth chart which we have plotted during the NICU stay. So we can see the growth pattern, how it is going, weight pattern, how it is going, its circumference, how it is going, length, how it is going, weight, how it is going. So this can be continued even in the follow. So 36 weeks, this Penton chart has till 50 weeks. So till 50 weeks, if you want to see the trend during follow-up, if the baby is coming once in 2 weeks, we can plot the weight here and we can see the trend and we can see whether there is any faltering. Or if the baby, so Penton chart is used in some places where the till 50 weeks we have room for infant chart. Till in intergrowth, till 44 weeks we can plot an intergrowth chart. And in Erin current, some units fall for less than 1.5 kg babies, they follow Erin current charts. This photocopies of this growth chart, as well as like preterm investigations checklist, this photocopy can be attached to the summary, so that it will be easy to follow these investigations as well as growth, how is the nutrition status of the baby, all these things, it will be easy to follow. And so WHO, if the baby is term or if the baby has already crossed EDD, yes, WHO growth charts can be used, and standard deviation can be seen. If the baby is between -2 to -3 standard deviation, when baby might be having moderate malnutrition. Baby is below -3 standard deviation, baby might be having malnutrition. So appropriately, we have to refer to a dietitian and we have to give a diet plan or modification of what practice the mother is already doing. So immunization, we give all our units, we have an immunization schedule attached in the developmental booklet. And what we can do is, we can pair this immunization visit and our follow-up visits together. So initially during the 1.5 months, 2.5 months, we'll be doing for any examination for any ongoing illness or any neuro behavior, neurological examination we can do at 1.5 months, 2.5 months, 3.5 months when the baby is coming for DPT vaccination. And ROP follow will be done clubbed along with this visits till the baby reaches term or 44 weeks post-menstrual age. And after that, OAE, as I already told, this hearing evaluation should be must. It has to be completed by 1.5 months or 6 weeks. Then this 3 months, 6 months, 9 months visits for neurological examination and developmental assessment, either screening test or formal assessment by Darcy. Everything can be clubbed in with the immunization visits. So you plan the visits such that both the things can be done in the same visit. We can avoid unnecessary travel by the parents. Hearing assessment, so hearing impairment, it has to be addressed, otherwise it will affect the language and communication skills of the baby. Remember the most important thing, 1, 3 and 6 rule, where hearing screening has to be completed by 1 month of age, and if there is any problem with the hearing screening, a complete comprehensive examination should be done by 3 months by an audiologist, and problem has to be picked up by 3 months of age. And before 6 months of age, intervention either in the form of hearing aid or implant has to be, cochlear implant has to be done. So we should not take more than 6 months of age in any baby who can have potential hearing loss. So universal hearing screening, all the babies born should be subjected to hearing screening. Any positive screening in your OAE, definitive testing, diagnostic testing has to be done, and intervention should be given. So OAE testing, the autoacoustic emission, this is a common screening test used in most of the units. It is a fast objective test. You can see a microphone which is kept inside the baby's ear, and signal or noise is given, and the response is seen. So integrity of the peripheral auditory system, cochlea and inner ear outer air cells. Till that point we can assess in the OAE. However, we can miss the auditory neuropathy. So only for high risk babies, like a baby who had eye bilirubin, who had required oxygen transfusion, which has asphyxia, whichever baby is coming in high risk category, we need to do this automated auditory brain stem response. So this is an electrophysiological measurement. It measures the response from the 8th node to the inferior colliculus in the midbrain. Here electrodes are placed in the forebrain. They are placed in the nape of the neck. They are placed in the mastoid, and it will give the test result. It won't give signals or noises of different frequency. It will just give the result as pass or fail. So in some places, two-step screening is done. Two-step screening means first screening will be OAE. If it fails, we will be going for auditory brainstem response. And if the baby passes this, we will be going for normal follow-up. If the baby fails, then we have to go for comprehensive diagnostic testing. However, AAP says that if the baby is falling under high risk category, we did a stratification, no? If the baby is falling under any of this high risk category, then baby has to undergo ABR, brainstem response, and not OAE. That is not adequate, and two-step approach cannot be followed for this high risk babies. But this two-step screening in otherwise well babies without any risk has an increased sensitivity and lesser false positive. However, so babies who fail this AABR should undergo comprehensive audiological evaluation before 3 months and intervention before 6 months. Rule of 136. This is a diagnostic BARA. Diagnostic auditory brainstem response. If we do when the baby fails automated ABR, then this requires some time. This requires some experience, and audiologist should be present, and anyone cannot do this diagnostic ABR. And but it gives the extent of hearing loss, and where is the site of hearing, site of the problem. Where is the problem exactly that is causing the hearing loss, and what is the extent of hearing loss? All this can be made only by diagnostic data. Even if we know that, only we can institute appropriate intervention. So it will give a wave pattern also. It will, the amplitude, latency, everything can be looked, and the area where there is problem can be identified by this diagnostic. So who are these infants with risk factors? No, we are telling, oh, they should not undergo OAE. They should undergo auditory brainstem response. They should undergo diagnostic ABR. These are babies where the caregiver has some concern. Is my baby might be having some hearing problem. There is family history of hearing loss. There is admission in NICU for more than 5 days. Baby has required ventilation, ECMO support. Baby has required gentamicin, ototoxic medication for a longer time. Baby has had some torch infection, craniofacial anomalies. All these babies are come under high risk. And these high risk babies, even if they have negative hearing screening, audiological testing, suppose baby has torch testing, but it has passed OAE or ABR, it is not sufficient. Audiological testing should be done every 6 months till 3 years of age, because there is always a risk of progressive hearing loss in these babies. And preterm babies, whenever we do less than 34 weeks, they don't respond properly, and they will tell, okay, hearing screening failed, like that they might tell. So in order to avoid this false positive, it is better to do screening after 34 weeks of gestation, 34 weeks post-menstrual age. So I need to, like, this slide I have put just to sensitize about a low-cost hearing screener, Soham. Soham Innovation has come up with this low-cost hearing screener. This OAE and AABR cannot be done in a noisy environment. So whenever there is noise, they will simply give redo. Come after 1 to 2 weeks for for redoing the OAE screening. So this advantage of this SOHAM is it can be done in a noisy environment. So you can record whatever waves that are coming. It can be uploaded to a server, and in a remote place, the audiologist can review the record and can say whether baby has any problem. And minimal electrodes are needed, and it provides high sensitivity and specificity, and it also the screening auditory brainstem response is it's conducted not only in 1 decibel, like 35 decibel, which we do in AABR. Here you can do in 3 levels: 35 decibel, 50 decibel, 70 decibel. So coming to ROP, why babies, preterm babies or even high-risk babies need a proper follow? Because this type 1 ROP, all of us known as type 1 ROP, is the one that is requiring treatment. Where you have ROP in zone 1 or zone 2, stage 2, 3 with plus disease, all those things come under type 1 ROP. So type 1 ROP, most of it require treatment, laser treatment, or we will be giving bevacizumab during NICU stay itself. But even after treatment, only 35% of the babies have proper visual acuity of 6 years of age, with a visual acuity of 20/40 or better. So ROP screening, whom we will be doing less than 1.5 kg babies and less than 30 to 32 weeks. This is what is given in recent Guwahati as well. Our NNF says less than 34 weeks of gestation, less than 1.75 kg babies or target or candidates for ROP screening. And when you, it can be done in NICU or step down, so that the proper dilatation, everything can be done, and pain measures can be taken, and any desaturation changes in vitals also can be monitored. And in many of the places, even in our unit, laser is also done in the NICU itself. So this will be better, so that we can monitor the baby as well during the procedure and after the procedure. And most important thing is we have to document what are the findings at each ROP visit, and what is the intervention done, and what is the next review date. So we have some record like this, where we will document which zone or which stage the baby is having ROP, and what are the comments of the ophthalmologist, when does he wants them to come for review. So why at all follow up in other babies who don't have ROP, who are not preterm? Those babies also it is needed, no? Because even those babies, we have high chance of refractory errors. High risk babies, they have high chance of refractory errors, strabismus, and late retinal detachment, even without ROP, or even with ROP which is not requiring treatment. High risk babies itself, they have high risk of all these adverse outcomes. And yes, a follow-up interval. So you have a finding, ROP finding. When do you want to ask the baby to come for follow-up? So NNF has given some follow-up criteria, like 1 to 2 weeks when it is in zone 1, when it is in zone 3. Okay, zone 3 is not of much problem. So the baby can come maybe after 2 to 3 weeks. Until it has completely regressed. So this is just to sensitize regarding innovative methods which have come in. So this is also been practiced in some parts of Karnataka as well, where wide angle retinal cameras are used instead of indirect ophthalmoscopy. These cameras can store images. These images can be captured by a trained nurse, doctor, or ophthalmic assistant. Trained ophthalmologist may not be needed, and indirect ophthalmoscopy, if we do not have expertise, that might not be needed. Just use the retinal cameras, RedCam, and capture the image and send it to a retinal expert, and these images can be stored and reviewed over time as well. However, there is some amount of cost involved, and the sensitivity is also variable. Eye evaluation, apart from ROP, 9 months we will evaluate for vision, whether the baby is able to fix and follow the image properly, and whether the baby has squint, cataract, or optic atrophy, and any subjective visual assessment, like already I told, inability to fixate or roving eye movements, nystagmus, all these things are noted subjectively. Objective visual acuity measurement by using TELUS acuity card by 9 months, and if there are any problems, just institute early corrective measures and rehabilitation. So coming to the neurological assessment part. Neurological assessment anyway as a part of systemic examination. Whenever baby comes to follow up, even in neonatal OPDs, we'll be doing a Hamilton angles. When a preterm comes for follow, we'll be seeing what is the posture of the baby, whether the baby is symmetrically moving both the sides, and we will be examining tone assessment, what is popliteal angle, Hamilton angles we will be seeing. So passive tone, we'll be keeping the legs in particular position, we will be measuring the popliteal angle, adductor angle, dorsiflexion. So those who don't know how to measure this angle, don't worry, I have put a video also for you to understand how to measure these angles. So we'll be putting the baby in prone position, we will be holding the baby in the axilla, and we'll be seeing what is the baby's response. This is also called as active tone. We'll be seeing whether primitive reflexes like grasp reflex, Moro's reflex are still present or they have gone. The primitive reflex, if they persist for a longer time, then it is not good. They have to be disappearing by 3 months of age. And then as the baby grows, we'll be seeing deep tenant reflexes, whether they are exaggerated, how it is, whether there are any contractures. We'll be seeing the head growth. We all know that the head has to grow 2 centimeter per month for initial 3 months, 1 centimeter per month for the next 3 months, and then later 0.5 centimeter per month for the next 6 months. Okay, so we'll be seeing how we will assess the tone of the baby on follow-up or in ICU. We'll be seeing a short 5 minutes video on the same. Next, let us check the passive tone and active tone of the baby. What do you mean by passive tone? Passive tone, baby is passive, that is silent. We make the baby's limbs in certain position and measure the angles. In active tone, we see baby's response to different types of maneuvers. Baby makes some active movements in active tone assessment. So, checking the passive tone, the assessment of the active tone and passive tone, the baby should be in state 3 or state 4 without crying, yet in midline and yet along the line with the trunk. And for us, so this is very important. Whenever we are measuring tone and angles, passive tone, it should be in midline. And for measuring lower limb tone, diaper has to be removed. And baby should be comfortable. He should not be crying as well. Baby should not be sleeping. If the baby is sleeping, then your tone assessment will be falsely wrong. You might measure hypotonia, but if the baby was sleeping. So baby should be alert, but baby should not be irritable or crying or sleeping. Assessing the tone of the lower limbs, we should remove the diaper as well. First, so now that we have kept the head in midline, we are trying to check the passive tone of the upper limb using scarf sign and arm recoil. In scarf sign, we are able to see that the elbow is not reaching the midline, just short of midline it is reaching. Whenever we are assessing tone or any sign in one side of the body, we should check in the other side as well to see whether any asymmetry is present. So we are checking in the other side. For arm recoil, we are keeping the hand, the flexed posture for 5 seconds and extending it and leaving. We see that immediately baby is flexing. So this is an instantaneous arm coil which is normal for a term baby. We will do the same in the right side of the baby as well. Coming to passive tone of the lower limb, we are now trying to check the popliteal angle of the limb. So while checking the popliteal angle, make sure that pelvis rests on the table and you don't lift the pelvis from the table. And flex the thigh over the abdomen and extend the legs at the knee. Check the angle between the legs and the thigh. Ideal way, we are checking the adductor angle where we keep the legs extended and try to spread the legs apart. So by visual inspection, angle comes to 80 to 90 degrees. So at the ideal way, we are checking using the goniometer. It comes to around 90 degrees, which was the same as the visual inspection. For checking the active tone, we need to perform the 180-degree maneuvers. So first we will check the tone of neck flexors. For that, we need to pull the baby from supine position to sitting posture. We can see that head is hanging back. And slowly when we try to make the baby to sit, there is some contraction in the neck muscles. And baby instead try to flex the neck and momentarily keeps the neck along the line of the trunk and then the head falls forward. So this is normal for a term baby. We can also see that the back of the baby is almost straight and it is not so much bent. It means that tone is normal. Now moving on to assessment of neck extensors. We try to put the baby from sitting posture to supine posture. And see that when we pull the baby slowly, the head tries to extend. Momentarily stands along with the trunk and then falls backward, which means that extensor tone is also good for the gestation. As a part of 180-degree maneuvers, we are checking the vertical suspension or axillary suspension of the baby. The baby, you can see that baby is trying to lift his legs and having some kicking movements. It means that tone of the lower limb is normal. Baby is not a floppy baby. Another component of 180-degree flip maneuvers is ventral suspension of the baby. On ventrally suspending the baby, you can see that he is trying to lift his head and keeps it along. It tries to lift the head and keeps it along the trunk momentarily for a few seconds. So which means that the tone is normal. Now putting the baby to prone posture. He is trying to lift his back. He is having movements of the lower limb. He is also trying to lift his head away from the ground. Let us move on to reflexes. First, checking the primitive reflexes. The baby has a rooting reflex and also baby was feeding well. To check a suck reflex, in exam we need to put the cloud finger inside the baby's mouth and see the strength of suck reflex in the baby. The grasp reflex, we are introducing our finger from the ulnar aspect of the and the baby grasps the finger. We are trying to check the plantar grasp by applying pressure to the base of the toes. Automatically plantar grasp is elicited. We are now trying to check the placing reflex by stimulating the dorsum of one foot. The baby places the other foot over the table and also by placing one foot over the table, baby automatically places the other feet as well, demonstrating the stepping reflex. Going to demonstrate Moro reflex. Having the baby inclined at an angle of 45 degrees, I am making the head to fall backward. So the baby abducts, extends, followed by adduction and flexion. It is usually followed by cry of the baby. And at times that cannot be there also. Baby is turning his head towards left side and automatically asymmetric tonic neck reflex is getting elicited with extension of the limbs on the same side to which the baby has turned his head. So we should make sure whenever we are examining tone, we should make sure that head is in midline. Fine. So now what we have seen is we have seen how to elicit, how to examine active tone and passive tone of the baby. And also we have seen how to see the reflexes, primitive reflexes of the baby. We have seen so different angles, Hamilton angles. How are you going to see? All those things we have seen in that video. So coming to the development assessment, okay, neurological examination, we are seeing angles, we are seeing active tone, reflexes, and then deep tendon reflexes, whether primitive reflexes are gone or still present. We are going to examine spine, cranium, all those things, and net growth, how it is we are going to do. Developmental assessment, many of the times, if there is any delay, we will be able to elicit the insult by antenatal history, perinatal history, and developmental, a proper developmental history from the mother itself will give a clue whether the baby has developmental delay, whether baby has more delay in the gross motor milestones or fine motor milestones. All those things can be elicited in the developmental history. Mother might be coming with a complaint of baby has not achieved end control, baby is not sitting with support, or mother might tell lower limbs appear very stiff, she is not able to put diaper for the baby. And we need to, even if there are no complaints, we will be doing screening test at least one about at least a screening test which has to be done before 6 months of age. And this developmental assessment should be correlated with the corrected age only, and age will be corrected, as I already told, till 2 years. So these photos also we have attached in our developmental follow booklet, where various milestones are given according to the age. So parents can go through this also and know whether if the baby is not able to do something in 3 months or 6 months, she can come back and say that yes, my baby has reached this milestone but has not reached. So this is like education to the parents, and they can also come back and give clue to us regarding any delay. So gross motor milestones, we all know that there are specific milestones which has to be achieved at each postnatal age, like 5 months, sitting with support at 7 months, sitting without support at 9 months, and fine motor like hand record by 3 months, bidextrous grasp at 5 months, and coming to language, one meaningful word at least by 12 months, and personal social names, one body part by 15 months. All these things we need to know, or we need to have a pictorial representation like what I showed before to check whether baby has reached the desired milestones. So if there is going to be no risk or mild risk for the baby who is going to be following up outside or with a primary care physician, or just follow up during immunization visit, the pediatrician can use a developmental screening tool, something like a development observation card, along with the CDC grading. So, 4 milestones gross age I'll check in the first year, like social smile whether the baby has reached by 2 months, head holding by 4 months, sit alone by 8 months, and stand alone by 12 months. And we should always make sure that the baby is able to see, hear, and listen. That is more important. Even if the gross motor milestone is normal, they should not miss something like a hearing disability, which can be easily picked up and addressed earlier. So there are CDC grading. So head holding, when the baby has completed 4 months, the baby should be falling in at least grade 3, 4, or 5, which is prone position, elevates arms, lifting the chest, all side steady when the mother is carrying the baby and moving around, and head is balanced at all the times. When you come to sitting, the baby should be able to reach grade 3, 4, 5 at least by 8 months. So sitting with the back straight while sitting, can turn around and manipulate a toy, raise a cell to sitting position. And when coming to standing, by completed 12 months, baby should be falling under either grade 3, grade 4, or grade 5. If the baby is falling in grade 0, where the baby is not able to do that milestone at all, even after completing that age, and if the baby is falling in a grade 1 or grade 2, that is abnormal, and we need to take it as a delay, and we need to go to a formal development assessment in that baby. And another screening test more commonly used is random screening test, where there are 27 items of cognitive and motor milestones. This is used for 0 to 3 years age group children, and it takes around 10 minutes to administer this random development screening tool. The preliminary training is enough to apply this tool. So here there are 27 items. Suppose if the baby is around 18 months, we will be drawing a vertical line along 18 months, and baby has to pass all the things which are present in the left side of that line. If the baby fails any of it, then it means that might be having a delay and baby needs a formal assessment of development. This is a TDSC for 3 to 6 years. Again, it has another 24 items, and we have to draw a vertical line based on the what age in months baby is falling. We need to draw a vertical line, and we have to make sure that baby is passing all the items which is towards left side of that line. Under screening test, a quick and simple screening tool is Denver Development Screening Tool 2. It is administered at least once, as I already told, at least once before 6 months of age it has to be done, and the next 6 months once, and once yearly till 5 to 6 years of age it has to be done. So it can be administered for babies between 2 weeks and 6 years of age. It consists of 125 items and takes around 10 to 20 minutes to administer. So the result will be either pass or fail, or baby was not given that item. There was no opportunity given to the baby to perform that particular skill, or baby refused, did not do that at all. So the inference can be any of it. Either you can mark it as pass, fail, or no opportunity, or refusal. The test kit is inexpensive only in TTST. All the items are put in a zipper bag, and there are test forms and a reference manual to check whether it is okay around. So similar to other things in Denver also, in DDST also, we have to draw a vertical line along the age of the baby, along the age of the baby. See, so this fellow is 13 months old. So I have drawn a vertical line in the 13 months. So there are, if you can see, there is a clear part and there is a shaded part. So if the baby is not able to do any of the items which is intersected in the shaded part. Suppose if the baby is not able to do this item, this item, this item, which are in the shaded part, then for each item it will be like a one caution. If the baby is not able to do the item which is towards the left side, so the way it is a delay. So whether if the baby is having two or more caution, or if the baby has one or more delay, then it means that there is some problem and rescreening has to be done in 1 to 2 weeks. And if it is also doubtful, or even in that the baby is not passing, having delay, it's not clearing items to the left side of the line, or there is a caution happening in the rescreening as well, then we have to go for formal development assessment. So formal assessment tools, there are many formal assessment tools. The most common used one are DASI, Development Assessment Scale for Indian Infants, which is used for babies between 1 to 30 months of age. There are 67 items for motor development, 163 items for mental development. This mental developmental index, motor developmental index, all these things we cannot put in a screening test. In DASI, we can put this developmental index and developmental quotient. So for DASI, we cannot do with inexpensive things which are commonly available. We need a proper kit. The kit might cost around 30,000, and the person who is administering DASI should have had formal training and should be certified in DASI. And some specifications are there for DASI. There should be a testing room. There should be preferably a soundproof room, and it should be fitted with a one-way mirror. A developmental psychologist or physician who has had formal training in DASI is needed. And developmental kit, as I already told, showing DASI developmental kit. So let us see how are some of the common 5 motor skills. How do we check whether the baby is passing those skills or whether the babies are failing? So the tools needed here are toys, rattles, cubes, raisins. So what do? We offer toy to the baby. We offer some 2 centimeter cubes. How we see how the baby approaches. What kind of grasp baby has, the palmar grasp, pydextrous grasp. So whether the baby is able to take the second cube when it is offered. When we give a pillet, we can see whether baby is having pincer grasp. See, this baby is having a bidextrous grasp, and the baby is trying to bring the object towards the mouth. This is called as mouthing. So again, we can have some cubes, beads, strings, pencil, paper, picture book as a baby grows. as a baby crosses 1 year, no, we can have all these things, and we can give the cubes to the baby, and we can see whether the baby is able to make a tower or train or build some bridge gate as a baby approaches 2 years. And we can give larger beads and a thread. We can see whether baby is able to put those beads into the thread. If you see this video, this baby is around 15 months old. She's offered some cubes. She took 2 cubes in the hand. She's able to hold 2 cubes. And the baby also takes another cube in the left hand. So baby will be around 15 months. So baby is normal, appears to be fine, motor skills appears to be normal. So this baby around 15 months of age able to build a tower with 2 cubes. And this child is around 2.5 years and is able to thread a larger beads into the thread. So when given a cube, the cubes are arranged imitating a train. By 2 years of age, by 2.5 years, the baby also attaches something called as something similar to a chimney to the train. And baby will be able to build bridge using the cubes by 3 years, and by 4 years, baby should be able to handle 5 cubes. And gate, baby is making it as a gate, and the gate can be moved out and inside gate can be opened. So we can, if the baby, as the baby ages further, we can use pencil and paper, ask the baby to draw a toy or man, something like man or house. And this we know that baby will be able to put a vertical line but 1.5 years, and horizontal line by 2 years, circle by 3 years, cross by 4 years, square by 4 years, triangle by 5 years, and a diamond by 6 years. And we can give some books, we can ask them to recognize colors, shapes, and we can give foam board and ask the baby to fit in circle, square. So these and all will be done in a particular age. So square and triangle baby will be able to fit in by 2 to 3 years. So this baby is identifying some familiar objects, and is able to turn some 2 or 3 pages at a time by 15 months of age. And by 15 months of age, when the baby is told I or some part of the body, baby is able to point to that particular part of the body. And BSID, Bailey scale for developmental assessment, is can be applied from birth to 3 years of age. Cognitive, language, motor, social, emotional, adaptive, behavior, competence, all those things are checked. However, the kit is a very standardized, and once we enter our findings, there will be online grading, and again this requires a formal training, and the person should be certified before he applies this Bailey scale of development. And this kit might cost around 1 lakh or so. So all those things should be considered. Our expertise and cost involved should be considered based upon the resources available in our unit before selecting a particular development assessment tool. So language assessment by 9 months and 18 months by using a list score. And if the child fails in any of the items, then we need to go for real scaling. So language and hearing, we can give common objects, and we can ask them, give me the ball, which the baby should be able to do by 1.5 years. Give the ball and give a cup. 2 commands we can give by 2 years, and the baby will be able to follow. And put the ball inside the cup. All those things baby will be able to do by 3 years. 3-step commands baby will be able to do by 4 years. And show me the cone, take some objects, show me this, show me the eyes and the body. All these things baby will be able to do by 1.5 years. We can assess language as well as hearing at this point. So other things are learning problems, intelligence, IQ assessment, cognition, behavioral assessment. All these things can also be done. So by 12 months of age, the cerebral palsy had to be picked up, and 1.5 months will be able to pick up any behavioral problems or attention deficit hyperactivity disorder. 2 to 3 months cognitive function can be assessed, and learning disorders can be assessed by 4 to 5 years of age. So interventions according to the problem, like motor impairment, medication, physiotherapy can be instituted. If the baby has disability or speech impairment, occupational therapy and speech therapy can be instituted. Anti-epileptics if the baby is going to have seizures, and if the baby is having DDH or CTEV, then orthopedic interventions and consultation. Squint correction, behavioral therapy, therapy for learning disabilities. Okay, so now all this assessment and extensively we have done, and we are following a multidisciplinary approach. So now the most important part is early intervention. Early intervention and early stimulation should be started even if the baby is in NICU. Developmentally supportive care should be given, which has some components well known like protected sleep, pain and stress management, daily living activities, family-centered care, eating environment, everything else. So when the DASI is abnormal even by 3 months of age, refer for early stimulation and early intervention. Tell them which room and which floor they have to go for early stimulation. So this is based on RBSK 2014. They have given some operational guidelines how to set up a district early intervention center. And screening, diagnostic assessment, domain specific intervention, evaluation and follow-up, everything will be done in this DEIC. And once the assessments are done, the baby general examination, reflexes, speech, language, receptive language, expressive language, cognition, play, everything will be done in DEIC. And it has given what are the things that has to be done in a DEIC, like visual assessment, occupational therapy, behavioral modification, physiotherapy, play therapy, parent training programs, all should be incorporated in a DEIC center. And it has given regulations, how should be the design of a district early intervention center should be, and what are the roles and responsibility of each DEIC staff, like a DEIC manager, physiotherapist, occupational therapy, dentition, and what are the roles they have, social worker. Specific roles have been assigned to each one of them, and equipment specifications. So how does different therapy equipment should look like, and how does rooms having rooms for that particular therapy should be designed. All those specifications is given in DEIC. And training program for DEIC has been reinforced in this Rashtriya Bal Suraksha Karyakram operational guidelines. So see, design soundproof room with carpet and one-way looking glass, and a speech therapy table with attached mirror. And first door separating the corridor and the soundproof room, second door separating the smaller and large room with one-way looking glass at the windows. So all these are specifications. Like these specifications are given for each area in a DEIC, like a play area, room with psychological tools, vision testing room. So it in detail, RBSK operational guidelines explain about each one. And another beautiful module brought up by RBSK, journey of the first 1000 days till 1000 days of life. From birth, what are the milestones baby will be reaching? It is given very simply, pictorial representation. Parents also can easily understand, and even a peripheral healthcare worker, Ranganadi worker, will be able to know that yes, baby is having some problem, some warning signs. I have to refer the baby to a IS center. So, and it is also says what most babies do at this age. The baby will begin to recognize the faces by 2 to 3 months, follows moving object, pays close attention and turn it towards voice of the mother. And what you should do: cuddle the baby, talk to the baby, play with your baby, attend to the cries, help your baby learn to calm himself, and pay attention to your baby's different cries, talk to the baby, read to the baby, sing to the baby. All these things, how and all you can provide early intervention even at home. Early stimulation, how the baby can be, how the parents can provide early stimulation according to the age of the baby. All these things are given in a detailed manner in the RBSK journey of the 1000 days. So similarly, learn age appropriate toys and learning through play. So these activities are also elaborated in the RBSK. Similarly, for 3 to 4 months, 6 to 8 months, all those things are given in this module. So coming to take home message, yes, follow planning should be done well ahead and well planned ahead of the discharge. Close monitoring of growth is mandatory, and in RBSK they have given like this. So rather than each individual seeing the child separately, it should be interdisciplinary. All the team members should see the child according to the problems which the baby has, and also there should be coordination among the team members also. And it is an interdisciplinary approach. The main thing is catch them young and intervene the babies early for the better outcomes. The main theme is catch the babies young when they are young and intervene early for better outcomes. So thank you for your patient listening. Any questions you can ask.